So, thank you, sir. Good evening, everyone. We are towards the end of the session for today, but here is a lengthy topic, so we'll move fast. I'm starting my topic with crystalloids. So, the most familiar one, normal saline, containing equal millimoles per liter of sodium and chloride, 154 millimoles each. No buffers, pH is on the acidic side in comparison to plasma, hyperosmolar, clinical significance, hyperchloremic metabolic acidosis, hypernatremia and volume overload. Next in line is Ringer's lactate. It has potassium and calcium besides sodium and chloride. Lactate is the buffer which gets metabolized in the liver to generate bicarbonate. pH is still acidic and it is a hypoosmolar. The most popular one, Plasma Light A. It has the most physiologic fluid in terms of electrolyte composition, pH and osmolarity. It has got acetate and gluconate as buffers which gets metabolized similarly to generate bicarbonate. So the most recent surviving sepsis campaign, they are of the opinion that the crystalloids are still the fluid of resuscitation. It is the fluid of choice. So previously they were of the opinion that you can go either for balanced salt solution or normal saline, but now they have suggested that they recommended actually that crystalloids again, the balanced salt solutions are preferred over normal saline. Regarding the volume, that we are not going for at least 30 ml per kg for all patients. It is based on the patient's hemodynamic status and dynamic methods of fluid responsiveness. Next is 3% saline or hypertonic saline. 1 liter contains 513 millimoles each of sodium and chloride. Osmolality is 1027 milliosmoles. Can be given either through peripheral line or ideally it should be given through a central line. Indications are rapid correction of symptomatic hyponatremia and treatment of raised ICP. Next is Vaptans or aquaretics. Their mechanism of action is by blocking V2 receptors in the kidney where they prevent recruitment of aquaporine water channels to the luminal cell membranes in the collecting duct, so they promote electrolyte free water clearance. Selective ones are tolvaptan, mozavaptan, non-selective ones which blocks both V1 and V2 receptors of conivaptan. Indication is you have first to rule out that patient is not hypovolemic. So the indications euvolumic like SIADH and hypervolemic SLD, CLD or congestive cardiac failure. In long-term use, conivaptan can cause derangement in the liver enzymes and transaminitis, which actually gets corrected once you stop the medicine. How aquaretics are different from diuretics? They do not interfere in the neurohormonal axis. So there is only free water clearance. So there is no interference in the serum potassium, serum osmolality, interference in the RFT or activation of norepinephrine or plasma renin activity. Next is 50% dextrose. It is non-pyrogenic hypertonic solution. Osmolarity is 25-23. It provides each 100 ml provides 50 grams of dextrose, which is equivalent to 130 kilocalories. Treatment is hypoglycemia, asymptomatic hypoglycemia of any cause, and as a adjunct to hyperkalemia treatment with or without insulin. This fluid is very rarely used in ICU setups, but still for the sake of completion, we will discuss 6% hydroxyethyl starch 130.4. You must be well acquainted with these numbers. 6% is the concentration of hydroxyethyl starch grams per 100 ml. 130 is the molecular weight and 0.4 is the degree of molecular substitution. That is the proportion of glucose units of the starch molecule have been modified with hydroxyethyl units. Indication, ideally in ICU there is no indication for using a colloid because it has got renal dysfunction, coagulopathy and fluid overload. Specifically in critically ill elderly patients, it should be totally avoided. You should go through these clinical trials, chest, bicep and 6S. All of them proves it is inferior to crystalloids. In the Surviving Sepsis Campaign 2021, they say for adults with sepsis or septic shock, we recommend against use of starch for resuscitation, and if at all you need any other fluid other than a substantial amount of crystalloid, you can go with albumin. Next is mannitol. It is available as 20% solution. Mechanism of action is through a rheological effect where it decreases blood viscosity, improves cerebral blood flow and oxygen delivery. In that way, it decreases cerebral blood volume. It creates an osmotic gradient across blood-brain barrier and acts as an osmotic diuretic, as well as it inhibits resorption of sodium in renal tubules. Indication is treatment of cerebral edema. Dose is 0.5 to 1 gram per kg over 20 to 60 minutes over 4 to 6 hourly. Other uses are reduction of intraocular tension, promotion of diuretic in certain toxicity, and antihemolytic in TURP solutions. So the reduction in ICP is dose dependent, and as it expands the plasma volume, it is contraindicated in heart failure, pulmonary edema, and severe dehydration. The cutoff for this is serum osmolality, so you have to stop it when the serum osmolality exceeds 320 milliosmoles per liter, or when the osmolar gap is more than 20. This is a table. In the first table, we use only mannitol 20% and 3% sodium chloride. So this is a comparative table where you can use either of the solution, but the gradients are different. Next is 3-chamber TPN, single packet, multiple compartments. It has to be premixed before starting over the patient. It contains fixed combination of amino acids, lipids, glucose, and electrolytes. Indication is non-functional GI tract, overlap to enteral nutrition. Precaution has to be taken before starting these in a oliguric patient or patients of severe hepatic failure or hypertriglyceridemia. Once opened, it has to be finished within 24 hours. You have to monitor LFT, triglyceride, blood glucose, and specifically phosphorus, because usually it is indicated in patients of refeeding syndrome. So further phosphate loss occurs after starting TPN, and patient may go into cardiac failure also. As it is a calorie-rich, dense fluid, it has to be used through a dedicated line. Correct severe fluid electrolytes and acid-base disorder prior to starting infusion of a TPN. The dose doesn't vary between a central TPN or peripheral TPN. When the triglyceride is more than 400, stop the TPN, wait for the triglyceride to come down. If the patient is already having a triglyceride more than 1000 milligram per deciliter, don't start TPN. The Surviving Sepsis Campaign 2016, they recommend against the administration of parenteral nutrition alone or in combination with enteral feeds over the first 7 days in critical ill patients with sepsis or septic shock for whom the early enteral feeding is not feasible. They have not commented that in 2021 guidelines. Omega-3 fatty acid, a oil-rich emulsion, total calorie it provides is 112 calories per 100 ml. Daily dose is 1 to 2 ml per kg, constitutes 10 to 20% of daily repeat requirements. Indications are severe ARDS, post-surgical, post-trauma patients, and patients of inflammatory bowel disease. Contraindication is severe liver or renal failure, intolerance to lipid. The same 2016 Survival Sepsis Campaign, they recommend against the use of omega-3 fatty acid as an immune supplement in critically ill patients. Amino acids, it is a supplement, not a sole nutritional fluid. Various concentrations are available, mostly we use 10%. The total amino acid is 100 gram per liter. Total nitrogen it provides is 16.2 gram per liter, and the daily dose is 16 to 20 ml per kg, equivalent to 0.8 to 1 gram per kg. It is a high osmolar fluid, so better to give it through a central line. Coming to 20% albumin, it is a 20% weight by volume, also 25% is available. Half-life is 19 days. The Survival Sepsis Campaign 2016, they suggest use of albumin when you have already resuscitated the patient with a substantial amount of crystalloids. Clinical trials you have to go through is SAFE and Albios. Indication are large volume paracentesis when you have already drained the patient more than 4 liters of ascitic fluid. The dose is 8 gram per liter drained. Spontaneous bacterial peritonitis, hepatorenal syndrome, both for diagnosis and treatment, plasma exchange, and MARS. Precaution has to be taken that critical illness, it actually worsens interstitial edema. There is a general misconception that when the patient is in septic shock, patient is having leaky capillaries, we think that albumin will actually hold the fluid inside the intravascular space, but that doesn't happen. Actually, the leaky capillaries are leaky to albumin also, so albumin will leak into the interstitial place and it will drag the fluid from the intravascular space. So again, it will get the organs more congested and patient will land up in multi-organ dysfunction. And second is hepatic impairment. It will worsen encephalopathy, and we have to be cautious when we use in renal impairment. Potassium supplements, we have got IV KCl, oral KCl, and POTFOS, potassium phosphate. We know the concentrations. 1 ml of IV KCl contains 2 milliequivalent. We have got 10 ml of ampule. It has to be preferably used through a central line. Maximum dose you can use through a peripheral line is 20 MEq per hour, and through central line we can use 40 MEq per hour. Side effects, if it is extravasated or when you use through a peripheral line, it can cause severe thrombophlebitis. Syrup formulation, 15 ml contains 20 milliequivalents, avoid in GI upset, ulcer, perforation. Potassium phosphate, it is available as 15 ml of ampule, and each ampule contains 3 millimoles of phosphate and 4.4 milliequivalents of potassium. It has to be diluted before using through central line, and it is frequently administered through with TPN. As we have discussed before, it can prevent initiation of refeeding syndrome. Sodium bicarbonate, it is a hypertonic solution and it is available in various concentration, but we use 7.5 and 8.4%. Mechanism of action is through correction of metabolic acidosis by buffering excess H plus ions. Indications are correction of acute, normal and ungapped metabolic acidosis and reversal of any metabolic acidosis, because severe metabolic acidosis impairs myocardial contractility. And in few drug toxicities like sodium channel blocker, salicylate, phenobarbital, methotrexate, we have to use for various mechanism of action. Side effect is hypernatremia, volume overload in patients those who are not generating enough minute ventilation. In those patients it can also cause CO2 narcosis, and crystallization of venous line after administration is there. Another option besides sodium bicarbonate is Carbicarb. It contains equimolar sodium bicarbonate and sodium carbonate. So, survival sepsis campaign, they are of the opinion that we should not, suggestion is against the use of sodium bicarbonate therapy to improve hemodynamics or to reduce vasopressor requirement. But for adults with septic shock and severe metabolic acidosis, when the pH is less than 7.2 and AKI with a Akin score of 2 to 3, we suggest use of sodium bicarbonate therapy. Calcium, two formulations are available, sodium chloride and sodium gluconate. Both are available as 1%, 10 ml, 10% weight by volume concentration. The gluconate chloride contains 3 times the elemental calcium concentration in comparison to calcium gluconate. Indication is in hyperkalemia as a membrane stabilizer, hypocalcemic tetany, hypocalcemia due to hypoparathyroidism, magnesium sulfate overdose. Interaction is the clinical interaction we encounter in ICU is increased risk of cardiac arrhythmia when you use with digoxin, and concurrent use of neuromuscular blockage agent may reverse their effect. Magnesium sulfate, it is available in 25% as well as in 50% weight by volume ampules. 1 ml contains 500 milligrams of magnesium sulfate, which is equivalent to 4 milliequivalents of magnesium. Indications are preeclampsia, eclampsia, hypomagnesemia and correction of hypokalemia. And in torsades de pointes. The last one is an off-level indication, severe bronchial asthma, where boluses of 5 to 10 millimoles over 20 minutes can be used. Insulin, the regular insulin available in our ICU is 40 units per ml. Indications are all hyperglycemic emergency related to diabetes as well as maintenance of normoglycemia in ICU and as a part of anti-hyperkalemic regimen. Clinical trials have to go through is biceps and eye sugar. Survival sepsis campaign 2021 recommends start insulin at a random blood sugar of more than 180 in patients with sepsis and septic shock. Propofol, the most familiar sedative hypnotic, it is available as 1% solution with soybean, glycerol and L-lecithin. 1 ml provides 1.1 kilocalorie of energy. Rapid onset, short acting, mainly eliminated through liver and cleared through kidney. Elimination half-life is 3 to 12 hours. Mechanism of action is potentiation with or without direct activation of inhibitory GABA receptors in CNS. Indication is rapid sequence intubation, sedation and status epilepticus. Propofol related infusion syndrome is it was first in history encountered in children when they have received more than 4 milligram per kg per hour for more than 48 hours of propofol infusion. The clinical signs include severe bradycardia as well as ventricular arrhythmias, lipemia, severe metabolic acidosis with a base deficit of -10, rhabdomyolysis, and the treatment is mainly conservative. Thiopentone, a less preferred drug for sedation. It is short-acting barbiturate available as 500 milligram as well as 1 gram pale yellow hygroscopic amorphous powder. It has to be diluted to a concentration of 25 milligram per ml. Mechanism of action is through GABA as well as benzodiazepine chloride receptors. Highly lipid soluble. The main indication we use in ICU is status epilepticus. Contraindication is acute intermittent porphyria. Dexmedetomidine, the agent of choice for awake sedation. It acts through central alpha-2 agonist, activates G protein in brainstem and inhibition of norepinephrine release. Half-life is 6 minutes, you know the dose, and the precaution is hypotension and bradycardia. Clinical trials is Prodex and Midex, where it has been compared with propofol as well as midazolam, where it has been proved to be non-inferior. But the incidence of hypotension and bradycardia is more with dexmedetomidine. Coming to benzodiazepines, sedative hypnotics enhances the effect of GABA receptor, decreasing the excitatory neurons. Indication we don't use for sedation, but it is the first line agent for treatment of seizures and anxiolytic agents, as well as it can be used for alcohol withdrawal. Commonly used agents are chlordiazepoxide, lorazepam, midazolam and alprazolam. Overdose antisept is flumazenil. Dose is 0.2 milligram over 15 minutes. It may precipitate seizure in chronic benzodiazepine overdose patients. Muscle relaxants, we have two categories, non-depolarizing and depolarizing. Non-depolarizing, we don't use vacuronium. Rocuronium, atracurium are used mostly. Atracurium is metabolized mostly by Hoffman's degradation and ester hydrolysis. Theoretically, there is incidence of laudanosine rise in blood, which can be a CNS stimulant and may cause seizure. Depolarizing muscle relaxant, it acts by binding to and activating acetylcholine receptors, at first causing contraction, then paralysis. It has to be avoided in severe burns, spinal cord injury. Survival Sepsis Campaign 2021 says don't use in continuous infusion, use intermittent boluses for patients whenever you need. Fentanyl, it is a narcotic analgesic. Mechanism of action is by binding to stereospecific various receptors at many sites. Onset of action is immediate. Coming to N-acetylcysteine, it is a mucolytic agent, but in our eyes, you use it as an antidote for paracetamol overdose as well as non-paracetamol induced fulminant liver failure. Mechanism is by protection through it protects the liver by maintaining and restoring the glutathione levels or by acting as an alternative substrate for conjugation with N-acetyl parabenzoquinonamine. So there are various regimens, you can go with either one. It is a controversial thing that whether it can protect against contrast-induced nephropathy or not, but it is not proven. Anti-epileptics, phenytoin, fosphenytoin, levetiracetam. Phenytoin, it stabilizes the neuronal membranes and decreases seizure activity by increasing the efflux or decreasing influx of sodium channels. It has a very narrow therapeutic index, so dose has not to be exceed more than 50 milligram per minute. Side effect is arrhythmia like ventricular fibrillation and hypotension. It can cause toxic hepatitis and leukopenia. Fosphenytoin, a rate of administration should not exceed 150 milligram per minute. Dose is 15 to 20 milliequivalent phenytoin equivalent. So one phenytoin equivalent is equal to 1.5 milligram per kg fosphenytoin. Levetiracetam, it is a pyrrolidine class of anti-epileptic. The mechanism of action is probably through inhibition of presynaptic calcium channels. Dose is 1 gram stat followed by 500 BD or TDS. Coming to anticoagulants, unfractionated heparin, low molecular weight heparin and fondaparinux. Unfractionated heparin potentiates the action of antithrombin 3, inactivates both factor 2 and factor 10. Onset of action through IV is immediate, subcutaneously it takes 20 to 30 minutes to act. Monitoring is through APTT. Low molecular weight heparin, we have got Clexane, enoxaparin and dalteparin. Mechanism of action is by binding to antithrombin, then it inhibits the factor 10. Usually we don't use any methods to monitor the levels, but still anti-factor 10A activity can be used. Advantage is less monitoring, less hemorrhagic complications with low molecular weight heparin. Fondaparinux, it binds to antithrombin 3 and causes selectively inhibition of factor 10A. There is no incidence of heparin-induced thrombocytopenia with it. Contraindication with fondaparinux that it has to be stopped when the creatine clearance is less than 30 ml per minute and if the patient is weight is less than 50. Indication is prophylaxis and treatment of DVT, treatment of PE, ACS, and these mechanical things like flushing of dialysis catheter and heparin lock in vascular catheters. Noradrenaline is a vasopressor. One ampule contains 2 ml and 2 mg of norepinephrine base. It stimulates the alpha receptor causing vasoconstriction, increasing the systemic blood pressure, and it stimulates the beta receptor causing ionotropy as well as increasing coronary flow. Dose is 0.04 to 0.4 microgram per kg per minute. Indication is shock of any cause. This survival sepsis campaign, they suggest that don't wait for the central line to be put before starting noradrenaline because the patient is in shock. You can start it through peripheral line. Adrenaline, it is one ampule contains 1 milligram in 1:1000 concentration. It stimulates beta 2 receptor at small dose. It can cause vasodilatation, bronchial smooth muscle dilatation, as well as with increasing dose, it stimulates the beta 1, then alpha receptor stimulation causing vasoconstriction. Indication is VT, VF, asystole, bradycardia, anaphylaxis, and bronchospasm. Vasopressin, 1 ml contains 20 units. Mechanism of action is through increasing cyclic AMP, which increases water permeability at renal tubule, resulting in low urine output. Causes intense vasoconstriction. Indications are vasodilatory stroke. Second, after norepinephrine, you can start vasopressin, and diabetes insipidus, and to reduce portal pressure as an alternative to terlipressin. Dopamine, it stimulates both adrenergic and dopaminergic receptors. This is the very famous dose related different pharmacological actions. 0.5 to 2 microgram per kg per minute. The action is only dopaminergic, where it causes renal and mesenteric vasodilatation. In 2 to 10, it is chronotropic, increases heart rate and mesenteric vasodilatation. 10 to 20, it causes vasoconstriction, rise in BP. Indications are bradycardia not responding to atropine, vasodilatory shock, inotropic agents in advanced cardiac failure. Dobutamine, inotropic agent, it stimulates beta 1 receptor causing increase in cardiac contractility and heart rate. Indication is inotropic support in advanced cardiac failure. Terlipressin, it is analogous to vasopressin. Indication is bleeding in esophageal varix and type 1 HRS. Dose is 2 to 12 milligram per day. Mechanism of action is same as vasopressin. It causes splanchnic vasoconstriction leading to reduction in hepatic blood flow and portal blood pressure. Side effects are hypertension, abdominal colic with diarrhea, skin ulceration and heart failure. Generally we avoid it in elderly patients and those patients who are already having a cardiac condition. Levosimendan, it is a calcium sensitizer. Indication is for the patients undergoing cardiac surgery who have impaired systolic function and acute decompensated heart failure despite maximal medical therapy. There is no bolus dose, only infusion is given, and infusion is to be given only for 24 hours. And hemodynamic benefit lasts for 1 to 9 days after stopping the infusion due to persistence of active metabolites. Contraindication is hepatic and renal impairment, hypovolemia, hyperkalemia, and you have to be careful before starting this medication when the patient is already having arrhythmias. Milrinone, it is a selective phosphodiesterase 3 inhibitor in cardiac and vascular smooth muscle. It has got a positive inotropic action as well as vasodilator. So it is popularly known as inodilator with little chronotropic effect. Indication is low cardiac output states due to impaired myocardial contractility. Available as 10 ml vial with 1 milligram per ml concentration. Dose has to be adjusted as per creatinine clearance and precaution has to be taken when the patient is having in shock and arrhythmia. These are the few guidelines we must be discussing it in sepsis class. Nitroglycerin, mechanism of action is through relaxation of vascular smooth muscle and dilatation of veins. Dilatation of vein promotes peripheral cooling and decreased venous return to heart. Arterial relaxation reduces systemic vascular resistance as well as afterload. It simultaneously dilates the coronary arteries and improves the perfusion. Indication is hypertensive crisis, control of congestive heart failure in acute myocardial infarction and treatment of angina. Contraindication where your cardiac output is dependent on the heart rate, then you have to ventricular response, then you have to stop it, like pericardial tamponade, restrictive cardiomyopathy and inferior valve MI. Nitroprusside, it causes peripheral vasodilatation by direct action over the venous and arterial smooth muscle, thus reducing peripheral resistance. It increases the cardiac output by decreasing afterload, reduces aortic and left ventricular impedance. Indication is hypertensive, emergency and urgency. Atropine, it is the classic anticholinergic. It blocks the action of acetylcholine at parasympathetic sites in smooth muscles and secretory glands. Mechanism of action, onset of action is immediate, half-life is 2 to 3 hours. Indication is hemodynamically significant bradycardia as a part of reversal of neuromuscular blockage and organophosphorus poisoning. Coming to antiarrhythmics, class 3 amiodarone, it is a class 3 antiarrhythmic. It has got multiple actions. Like class 1, it blocks sodium channels. Like class 2, it has got non-competitive antisympathetic blockage. Main action is as class 3 antiarrhythmic, where it lengthens the cardiac action potential, prolongs refractory period, decreases AV conduction and sinus node dysfunction. A dose is 150 milligram over 10 minutes and 360 milligram over next 6 hours. Monitoring, you have to monitor QTC. Indication is ventricular arrhythmias. Side effects are bradycardia, pulmonary fibrosis over long-term use, liver dysfunction. Diltiazem, it is antiarrhythmic as well as anti-anginal calcium channel blocker. Mechanism of action is through inhibition of extracellular calcium ion influx across the membrane of myocardial as well as vascular smooth muscle cells. Results in inhibition of cardiac and vascular smooth muscle contraction. Indications are hypertension and arrhythmia. Adenosine, it is administered through IV and indications are conversion from paroxysmal supraventricular tachycardia to sinus rhythm. Available as 2 ml vial, contains 6 milligram and it is compatible with NS. Stored at room temperature. It has not to be refrigerated. It is crystallizes below temperature of 10 degrees Celsius. Given as a rapid IV bolus as close to the patient as possible and followed by a rapid saline flush. The recommended IV dose for adult, the initial dose is 6 milligram. You can repeat the bolus dose. Metoprolol, it is a selective beta-1 blocker. It is used for angina, myocardial infarction, atrial fibrillation, supraventricular tachycardias. Xylocard, lignocaine, it is used as antiarrhythmic. It blocks the sodium channels in the cell membrane of the heart, and ventricular excitability is depressed, and stimulation threshold of ventricle is increased. Indicated for cardiac arrhythmia and status epilepticus. Coming to the family of diuretics, we have got thiazide, loop diuretics, potassium sparing diuretics, and carbonic anhydrase inhibitors. The most common ones we use is Lasix, spironolactone, and Diamox. Uses are for loop diuretics, edema due to cardiac failure, hepatic disease, nephrotic syndrome, acute pulmonary edema, and cerebral edema. Not very justified use. Acute chronic renal failure, barbiturate poisoning, and salicylate poisoning, just to flush out the drug from the body. Adverse effects are hypovolemia, electrolyte disturbances. It also increases blood glucose level and uric acid levels. Ototoxicity. Ivabradine, the primary action is through SA node. It inhibits the inward funny current, increases the duration of diastole, used in heart failure with reduced ejection fraction, as it does not target the neurohormonal system. The main adverse effect is bradycardia, and it has a 15% increase incidence of atrial fibrillation, and it is used for the treatment of inappropriate sinus tachycardia, but it is not FDA approved. Family of steroids, we have got short-acting, intermediate-acting, and long-acting steroids. Hydrocortisone, prednisolone, methylprednisolone, and dexamethasone are the most commonly used ones in ICU. You have got the dose and comparative ratios in terms of anti-inflammatory and mineralocorticoid potency. Indications, airway and breathing, like pneumocystis cerevisiae, pneumonia, croup, anaphylaxis, asthma, COPD, acute exacerbation, previous steroid use. Nervous system, like bacterial meningitis, myasthenia crisis. Endocrine, hypercalcemia, Addison's, myxedema, coma. Accepted but controversial use of steroids, sepsis with resistant shock, spinal injury, early ARDS. Contraindication to use of steroids are Cushing's disease, traumatic brain injury, and late ARDS. 2016 sepsis guideline suggest against the use of intravenous hydrocortisone to treat septic shock patients if adequate fluid resuscitation and vasopressin therapy are able to restore hemodynamic stability. These are the group of adverse effect. Okay, I'm done with the last slide. Thank you.